Bismillahirrahmanirrahim. Now on to the third session. So the first point is the sinus bradycardia. So in the sinus bradycardia, the uh, the heart rate is less than 60. The rhythm is regular. P wave is present before each QRS and that is identical. The PR interval is of normal duration, that is 0.12 to 2.2 seconds. Okay, now the dispute is clear. It was not millisecond, it is seconds. QRS is normal duration less than 0.12 seconds and it is also of normal shape. So this is the picture of sinus bradycardia. Okay, so here you can see that this is the PR interval, the PR segment, ST segment, QRS interval, QT interval, the ST interval, and this is basically a normal picture. Like uh, this is a cube 5 millimeter to 5 millimeter. The width is depicting 0.2 seconds time, and the height is depicting 0.5 millivolts voltage. The ECG interpretation: heart rate is the number of RR intervals within 6 seconds multiplied by 10 for irregular rhythm. Okay, so the number of RR intervals within the 6 seconds. So it is 0.2 seconds. So okay, yeah, okay, count it up till 10 second, up till 6 seconds. So yes, listen, count up till 6 seconds and then multiply that with 10, so that's the heart rate. For irregular rhythm, count the RR interval for a full 60 seconds for accuracy. Measure the RR interval to determine the regularity. Evaluate P waves. Are the P waves present? Is there a P wave for every QRS? Are the P waves looking identical? Measure and evaluate the PR interval and measure the QRS and examine its configuration. Okay, then we have approach to the sinus bradycardia in adults. If the pulse is less than 50 minutes and symptomatic, like for example dizziness, assess the appropriateness for the clinical condition, identify and treat the underlying cause, IV access cardiac monitoring to identify the rhythm, pulse oximetry with oxygen for hypoxemia, and 12 lead ECG if possible. Do not delay the therapy. Persistent bradyarrhythmias and one of the following, like hypotension or signs of shock, acute mental status changes, chest discomfort concerning for the cardiac ischemia and acute heart failure. If these things are not present, then monitor the patient and observe him. If these things are present, then IV atropine 0.5 milligram bolus, repeat every 3 to 5 minutes up to 3 milligram maximum. And if still there is no response, transcutaneous pacing, that is a bit painful, or we can give IV dopamine 2 to 10 microgram per kg per minute infusion, or we can give IV epinephrine 2 to 10 microgram per minute infusion. And if still there is no response, consider expert consultation or transvenous pacing. Lab evaluation of hypertension. So for hypertension, mostly hypertension is primary, but to look for secondary causes, if any, we do renal function test. We check for the serum electrolytes, sodium, potassium, calcium, serum creatinine, urinalysis, and urine albumin creatinine ratio, which is optional. Endocrine tests like fasting blood glucose or hemoglobin A1C, lipid profile, and TSH. The cardiac tests like ECG and echocardiography, which is optional, and other tests like complete blood count and uric acid, which is also optional. Indications for defibrillation. Firstly, ventricular fibrillation and pulseless ventricular tachycardia. Shockable and non-shockable rhythms. The shockable rhythms include ventricular fibrillation and ventricular tachycardia. The non-shockable arrhythmias include asystole and pulseless electrical activities, which these will not be cured with shock, and these can be cured with shock. Then we have approach to the management of cardiac arrest. So for the approach of to adult cardiac arrest, start the CPR and give oxygen and attach the monitor defibrillator. If it is ventricular fibrillation or pulseless ventricular tachycardia, start defibrillation. Defibrillation shock is given. CPR for 2 minutes, airway, intravenous or intraosseous access, and epinephrine every 3 to 5 minutes. Pulse and rhythm check every 2 minutes and treat the reversible causes. Okay. If it is a shockable rhythm, give like ventricular fibrillation or pulseless ventricular tachycardia, give a defibrillation shock. If it is okay, so after doing all of this, there can be return of spontaneous circulation. And if it is an unshockable rhythm, like PEA, pulseless electrical activity, or asystole, so give CPR for 2 minutes, airway, intravenous or intraosseous access, epinephrine every 3 to 5 minutes. So this is how you perform. how you approach an adult with a cardiac arrest. Okay. Then we have detailed approach to the adult with a cardiac arrest. So this is approach to the adult with a cardiac arrest. Start CPR, give oxygen and attach, monitor the defibrillator. Ventricular fibrillation and pulseless ventricular tachycardia. Give shock. Then give CPR for 2 minutes and obtain the IV access. If the rhythm is shockable, uh, give the shock and then again repeat CPR every 2 minutes, epinephrine every 3 to 5 minutes, possible advanced airway. Okay. And then if the rhythm is shockable, so give a shock, CPR 2 minutes, amiodarone and treat the reversible causes. Okay, and if the person is having asystole or pulseless electrical activities, give CPR for 2 minutes, maintain the IV access, epinephrine every 3 to 5 minutes, and possible advanced airway. If the rhythm is shockable, check if the rhythm is shockable. If it is not shockable, again give CPR for 2 minutes and treat the reversible causes. Now, if the rhythm is shockable, so give the shock, and if it is not, so again give CPR for 2 minutes, IV access, epinephrine every 3 to 5 minutes, and possible advanced airway. Okay, then we have indication of synchronized cardioversion. Narrow or wide QRS complex tachyarrhythmias like atrial fibrillation, atrial flutter, ventricular tachycardia with a pulse. Indications for transcutaneous pacing, symptomatic bradyarrhythmias, and complete heart block. CPR. Elapsed time to effective resuscitation in CPR is most critical factor determining the overall patient survival in sudden cardiac death. Contraction only CPR shows better outcomes than standard CPR with rescue breathing. Hepatomegaly. Why have they written it here? I don't know. But okay, hepatomegaly is the liver size may be estimated by the degree of extension of liver edge below the costal margin or by span of liver dullness to percussion. Okay. In children, liver edge may be normally palpable up to 2 cm below the right costal margin. So more than 1 cm below the right costal margin is hepatomegaly. And this is 4 to 8 cm in the mid-sternal line and 6 to 12 centimeters in the right mid-clavicular line. I believe it was by mistake. So what are Canon A waves? Here you can see jugular venous pulsations. If I decode these waves for you, so the jugular venous waveform is basically the reflection of the atrial pressures, which are, because this is, suppose this is the heart, and above we have the atria and below the ventricles. So this atrium is connected to the superior vena cava. The superior vena cava is connected with the subclavian vein, and the brachiocephalic vein, and the brachiocephalic vein is connected uh, with the jugular veins. What about carotids? Okay, there is, I just forgot a bit of anatomy. Let me check that. So yes, the thing is that this is left subclavian vein. This is the right internal jugular vein. I have to remove it. This one. Okay. So this is the right internal jugular vein. Then here we have the left brachiocephalic vein, uh, which is draining into this, and this is going to give subclavian vein and also the left internal jugular vein. So okay, so I'm talking about the jugular vein, the right internal jugular vein or the jugular vein. Now the pressure changes which are happening in the right atrium, they can be visualized in the jugular vein in the neck, and they can also be recorded in the waveform. Now these waves, the A wave corresponds to the atrial contraction during atrial systole, right? When the atria contracts and the blood is pushed into the right ventricle. Normally, the blood from the right atrium is moving passively through the right ventricle when the mitral valve is opened. And then comes the atrial systole, in which the remaining 20% of the blood which is still in the atrium is pushed into the right ventricle. So that corresponds to the A wave. Then after that, after the atria has contracted, like suppose after the atrial contraction, the tricuspid valve closes, and now the ventricle is undergoing systole, right? When the ventricle is contracting, this ventricle contraction pushes the tricuspid valve slightly into the atrium, that creates a C wave, right? Then comes the X descent. This X descent is when after the systole, after the ventricular systole, the atrial wall is relaxing and more blood is moving into the atrium, that is X descent. Then comes the V waveform. The V waveform corresponds to the maximum. Now the blood is entering and the walls are relaxing. This was X descent. When the walls have dilated to its maximum, and now the blood is filling the atria, more and more blood starts exerting the pressure on the walls, and we get a maximum amount of blood, that is this V wave, right? And then the tricuspid valve opens. This blood moves passively into the ventricle, and we have a Y descent. This Y descent is followed by the A wave when the atria starts contracting. Now you can see that there's a rise in pressure. Atria have started to contract, and the maximum contractile force is seen in the A wave. The whole concept was to tell you about the Canon A waves. Now, what is the Canon A wave? The thing about Canon A wave, okay, I have to remove all of it. So you can see that suppose this is the heart, and here we have this atrium ventricle division. If there is some stenosis or obstruction of the tricuspid valve, or if there is no obstruction, actually this is not because of obstruction, this is because of a different reason. uh, it is because of atrial ventricular dissociation. Okay, when the atria contract, but the mitral valve is not yet opened, so the atria contract against a closed mitral valve. Like suppose when there is AV dissociation, like suppose the ventricles are undergoing systole, and it was the time when atria was supposed to relax, but because of AV dissociation, if the atria start contracting simultaneously, so the tricuspid valve is closed. This when the atria contract against a closed mitral valve, the atrial pressure rises, and that rise in atrial pressure is seen as a Canon A wave, as you can see in this picture. So this is the normal, and this is the Canon A wave, as you can see here. These waveforms are intermittent, prominent A waves caused by the surge in the jugular venous pressure that occurs due to the right atrial contraction against a closed tricuspid valve. These waves can be seen in atrioventricular dissociation like ventricular tachycardia, complete AV block, frequent premature ventricular contractions. Now, complete heart block is an example of AV dissociation. In this, the atria are beating under the influence of SA node, right? And the ventricles are beating under the influence of AV node, or maybe most probably AV node, but some ventricular pacemaker. So this is ventricular rate is 20 to 60. That is the AV pacemaker node, AV pacemaker rate, and the atrial rate is 60 to 100, which is the SA pacemaker rate. So here you can see that this is a P wave, then comes another P wave, this one, then P wave. So like P waves and QRS complexes are happening at equal intervals. Like the R interval is equal to each other, and the P to P interval is same, but they're just happening at independent of each other. Atrial and ventricular rhythms are regular but independent of each other. Then we have acute pericarditis. So acute pericarditis means inflammation of the pericardium that is lining the heart, right? Now, cardiac tamponade is a complication of pericarditis, right? So, like suppose this is the heart and it is encased in the pericardium. If it is inflamed, so there can be accumulation of fibrinous material inside the pericardium, and yeah, so that will lead to obstruction of the heart from outside, and that can lead to cardiac tamponade. Yes, because that there will be accumulation of fluid in the pericardial space, and that will not allow the heart to relax properly. So that will be seen. And pulsus paradoxus is a characteristic of cardiac tamponade. Pulsus paradoxus means with inspiration, normally there is a slight decrease in the blood pressure because the blood is pulling into the heart. But if that decrease in blood pressure is more than 10 millimeters of mercury on deep inspiration, that is called as pulsus paradoxus, and that can be seen in cardiac tamponade. So what are the etiologies of pericarditis? Firstly, we can have infectious etiologies like viral, which is most common, or bacterial. Iatrogenic, like due to some medical procedure, for example, when we were doing some surgery, trauma, radiation, or drug related. Connective tissue disease like rheumatoid arthritis, systemic lupus erythematosus. Cardiac complications like Dressler syndrome. Dressler syndrome is an autoimmune pericarditis that can happen weeks to months after a myocardial infarction. It is post-myocardial pericarditis, usually 1 to 6 weeks after the myocardial infarction. Uremic causes serum BU and usually more than 60 milligram per deciliter, but the degree of pericarditis does not always correlate with the degree of elevation. And malignancy, it can be due to cancer, for example, lung and breast, Hodgkin lymphoma, or treatment, for example, radiation and chemotherapy. Presentation, pleuritic chest pain, it radiates posteriorly to the bilateral trapezius ridges. Okay, so the pleuritic chest pain will radiate posteriorly to the bilateral trapezius ridges, lower aspect of the bilateral scapulae. Fever, triphasic pericardial friction rub head at the left sternal border. It heard it's heard at the left sternal border. It is heard in the atrial systole. The friction rub is heard during the atrial systole, ventricular systole, and early ventricular diastole. The diagnosis is with ECG. On ECG, you will find diffuse PR depression due to inflammation of the atrial myocardium, and there will be diffuse ST elevation due to the inflammation of ventricular myocardium. It eventually evolves to diffuse T wave inversion. The ST elevation in the pericarditis is different from the ST elevation in the myocardial infarction or angina. In ST elevation myocardial infarction, it is different from that. How? Because in ST elevation myocardial infarction, the ST elevation is tombstone shaped. Like suppose this is the QRS interval and this is that. So there's a tombstone appearing ST elevation. While in the case of pericarditis, this is the QRS interval, and then we have a ST elevation like this. Like it is a smiley face. There's a indentation in that, and then it moves upward. So they just look slightly different in both of these situations. Then we have pericarditis can lead to cardiac tamponade assessment. Lungs are clear and tamponade. Okay, so echocardiography will show pericardial effusions. Now in this picture you can see that there is we are looking for PR depression, right, and ST elevation diffusely. So you can see this ST elevation in V4, V5, V6, even in V3. Like this is ST elevation. After the QRS, the ST is elevated, right? Even here there is slight elevation in the ST segment. In the lead V1, you can see elevation of ST. So this is happening, and I guess this is a characteristic smiley face ST elevation as well. And there is T wave inversion too. So this is diffuse ST elevation. In all the leads, you can see that the ST segment has elevated, and the T wave is also inverted. As you can see in this picture, they have highlighted that ST elevation here and here. Okay, so the treatment of pericarditis is with the NSAIDs. They are the first line. We can also give colchicine. It decreases the rate of recurrent pericarditis. Corticosteroids. In patients with a contraindication to NSAIDs like renal insufficiency, we can give them corticosteroids. In patients who do not respond to NSAIDs, pericarditis occurring within 7 days of MI should not be treated with NSAIDs other than aspirin or corticosteroids. This is because it leads to impairment of scar formation. It is a very important point that NSAIDs must not be given to any patient within 7 days of myocardial infarction, because it is a very critical time when the scar is being formed. If we give NSAIDs in this time frame, so the scar formation will be hindered, which increases the risk of pre-wall rupture. We can give aspirin and colchicine in these cases. Aspirin can also be given in the patients who need concomitant antiplatelet therapy. Differentials: costochondritis. It is an inflammation of the parasternal cartilage. Patients present with chest discomfort that is worse with the movement and reproducible with the chest palpation. Viral pleurisy. Pleural rub is differentiated from pericardial friction rub by a disappearance during the breath holding. Okay, so this is a table about acute pericarditis. The etiology is viral or idiopathic, autoimmune like SLE, uremia, acute or chronic renal failure, post myocardial infarction, early peri-infarction pericarditis 2 to 4 days of MI, and the late is Dressler syndrome 1 week to month after MI. So you have to differentiate between these two. The clinical feature and diagnosis: pleuritic chest pain decrease when sitting up with or without fever. The pericardial friction rub is highly specific. ECG diffuse ST elevation and PR depression. Echocardiogram will show pericardial effusion. Treatment is with NSAIDs and colchicine for viral or idiopathic and variable for other etiologies. Treatment is supportive or high dose aspirin for the pain, no NSAIDs or steroid in the post-infarct pericarditis, right? Yes, in post-infarct pericarditis, you're not supposed to give NSAIDs, neither steroids. Give aspirin or colchicine. Then we have constrictive pericarditis. So constrictive pericarditis is a variant of pericarditis. It occurs as a result of scarring and subsequent loss of normal elasticity of pericardial sac. Now the pericardial sac have become stiff, right? It can't expand. It is not elastic anymore. It is due to fibrosis with obliteration of the pericardial space. Etiology: idiopathic or viral, most common cause in USA. Then cardiac surgery, radiation therapy, TB, most common cause in endemic areas, and uremia. It is common in survivors of Hodgkin lymphoma due to mediastinal irradiation or anthracycline therapy. It presents 10 to 20 years after Hodgkin lymphoma treatment. So the history of Hodgkin lymphoma is an important diagnostic clue, because the people with Hodgkin lymphoma would have received mediastinal irradiation, which can lead to constrictive pericarditis. The features are right heart failure. The right, in constrictive pericarditis, this is the heart and this is the stiff pericardium. It is exerting pressure on heart on all the sides. Because the right side of the heart is low pressure system, it faces the brunt the most. So there will be right heart failure. The right heart won't get enough blood. It won't be able to relax properly. So because of right heart failure, we will be getting peripheral edema, ascites, and increased jugular venous pressure. Normally is less than 8 centimeter of water, but in these cases it will be higher. There will be pulsus paradoxus, Kussmaul's sign, which is lack of decrease or increase in jugular venous pressure on inspiration, pericardial knock, mid-diastolic sound, not murmur, cardiac cirrhosis, hypoalbuminemia due to the protein losing enteropathy, likely from intestinal lymphangiectasia in the setting of increased systemic venous pressure. So when there is increase in systemic venous pressure, there is going to have there is going to be intestinal lymphangiectasia, which means that the lymphatic vessels in the intestine will become dilated and they will not uh, reabsorb the proteins, right? So due to some reason, there's going to due to this reason, there is protein losing enteropathy, and that can result in hypoalbuminemia. Diagnosis is with the chest radiography. Pericardial calcifications will be seen, and echocardiography is confirmatory. Increased pericardial thickness, abnormal septal motion, and biatrial enlargement. The treatment is with diuretics that can give temporary relief, and pericardiectomy is the definitive treatment. Features of constrictive pericarditis, most of them are right-sided heart findings. There will be diastolic failure. So etiology is idiopathic or viral pericarditis, cardiac surgery or radiation therapy, tuberculous pericarditis in the endemic areas. The clinical presentation are fatigue and dyspnea on exertion, peripheral edema and ascites, increased jugular venous pressure, pericardial knock may be heard, pulsus paradoxus and Kussmaul's sign. The diagnostic findings include ECG may be non-specific or show atrial fibrillation or low voltage QRS complexes. Imaging shows pericardial thickening and calcification. The jugular venous pulse tracing shows prominent X or Y descent. It is very important that in the cases of cardiac tamponade, the X descent is not visible. The X descent is gone. Not X. I guess the Y descent. Yes, in cardiac tamponade, the Y descent is not present, while in constrictive pericarditis, the X and Y descents are prominent. You must remember that point. The pulsus paradoxus, it is exaggerated drop in the systolic blood pressure more than 10 millimeters of mercury during inspiration. It is seen in cardiac tamponade, which is most common, then in severe asthma, COPD, and hypovolemic shock, and also in the constrictive pericarditis. Note, if the patient has aortic regurgitation, left ventricular end diastolic volume increases so much that even in the case of pericardial effusion or cardiac tamponade, pulsus paradoxus does not occur as the increased left ventricular end diastolic volume prevents the septal deviation into the left ventricle. If the patient has aortic regurgitation, left ventricular end diastolic volume increases so much that even in the cases of pericardial effusion or cardiac tamponade, pulsus paradoxus does not occur. Okay, now listen, why does pulsus paradoxus occur? They're trying to tell you that normally this is the heart and I'm not drawing the pericardium. Okay, let's draw it. This is the pericardium, and the pericardium is filled with blood, or maybe there is some effusion, or maybe there is some constriction, but the heart cannot expand outwards. When this right ventricle cannot expand outward, it starts expanding into the left ventricle. How? During ventricular diastole, the right ventricle fills first, right? The right ventricle is filling with the blood coming from the right atrium. So also in the meanwhile, the left atrium is also filling, but this cannot expand outward. So instead, it pushes the interventricular septum into the left ventricle. So the interventricular septum comes somewhat like this. So the space for the left ventricle is very low. So the preload, so the amount of blood which can enter the left ventricle decreases, and this is happening specifically during inspiration. Why inspiration? Because during inspiration, the blood flow to the right heart increases, and that increased blood flow to the right heart will push the interventricular septum into the left ventricle, and the left ventricular volume will decrease. But in the conditions where the people are having aortic regurgitation, due to aortic regurgitation, The left ventricular volume is already high because the blood from the aorta regurgitates back to the left ventricle. So the left ventricular volume is already high. Even on inspiration, the interventricular septum will not be pushed into the left ventricle, and thus, with the people who have aortic regurgitation, the pulsus paradoxus is not seen. So if the patient has aortic regurgitation, left ventricular and diastolic volume increases so much that even in the case of pericardial effusion or tamponade, pulsus paradoxus does not occur, as increase in left ventricular and diastolic volume prevents a septal deviation into the left ventricle. Cardiac complications of the Hodgkin lymphoma. Acute or delayed pericardial disease, myocardial infarction, restrictive cardiomyopathy, congestive heart failure, valvular abnormalities, and conduction defects. Now, what condition cause pulsus paradoxus? Acute asthma, congestive heart failure, chronic obstructive pulmonary disease (COPD), cardiac tamponade bleeding from the heart, tension pneumothorax, that is air leaking from the damaged lungs, and pericarditis, swelling of the pericardium. Then uremic pericarditis, it is happening in the under the settings of chronic kidney disease, and uh, yeah, when the blood urea nitrogen level is BUN level is very high. It is associated with a renal failure and occurs in the patient with a BUN level more than 60 milligrams per deciliter. The features are pleuritic chest pain, often radiating to the back. It is worse in supine position and improves with sitting up. The pericardial friction rub, high frequency grating or squeaking sound, best heard at the left sternal border with the patient leaning forward. The rub may occur during systole, diastole, or both. Treatment is with dialysis. As more than 50% cases are accompanied by the pericardial effusion, the cardiac tamponade should be ruled out prior to the dialysis initiation. Differentials. Acute pericarditis due to other causes is a differential for uremic pericarditis, because uremic pericarditis does not show classical ECG findings of pericarditis, that is diffuse ST segment elevation or PR depression. These things are not seen with the uremic pericarditis. This is because the inflammatory cells do not enter the myocardium. Okay. So causes of pleuritic chest pain. The pleuritic chest pain can be caused by costochondritis, pericarditis, malignancy, and infection, for example, pneumonia. Costochondritis, these are the costochondral junctions, and if there is some inflammation over here, so that can lead to costochondritis, I guess. Sternochondral joint, this is sternum, and the parasternal cartilage. If the musculoskeletal chest pain, it is a musculoskeletal chest pain with more than one anterior chondral joint, costochondral or sternochondral joint tenderness. So there will be costochondral or sternochondral joint tenderness at more than one locations. It is often caused by joint aggravation during the physical activity. Presentation, localized pain of the anterior chest. It worsens with movement, deep inspiration or coughing. Physical examination is tenderness to palpation and no swelling. Management is reassurance along with topical or systemic analgesics. Pericardial effusion. It is the collection of fluid in the pericardial space. The pericardial effusions are often secondary to viral pericarditis. The viral pericarditis can cause the accumulation of fluid in the pericardial space that will result in pericardial effusion. The chest X-ray reveals enlarged cardiac silhouette, that is water bottle shaped heart with clear lungs. It is very important that in pericardial effusions and tamponade we are having clear lung fields. Okay. Presentation is Beck-Stired. Beck-Stired include hypotension, increased jugular venous pressure more than 8 centimeter. Okay, less than 8 is normal, and muffled heart sounds. Point of maximal apical impulses cannot be palpated in the patients with large pericardial effusion. The diagnosis is done with EKG. In EKG, you will find electrical alternance. QRS complex whose amplitude vary from beat to beat. Why is that happening? You can see that this QRS complex is larger than this one, and this is larger, and again there is a smaller one. It is happening because suppose this is the heart, and here we have a pericardial cavity which is filled with some fluid. So the heart is literally swinging back and forth in this fluid cavity, and here we have our probe attached. So when the heart comes close, the QRS is detected, as a the QRS is amplified, and when the heart is moving backwards, the QRS recording is diminished. So it is because of this swinging activity of the heart that we are getting electrical alternance, which is varying amplitude of the QRS complexes. Then we have purulent pericardial effusion. Purulent means pus filled, so it is definitely associated with some infectious etiology. Not always. So purulent pericardial effusion, hematogenous or direct intrathoracic spread. Yes, it is associated with infectious etiology. Now that infection can either be spread via hematogenous route or by direct intrathoracic spread. The risk factor are immunosuppression, hemodialysis, recent thoracic surgery or trauma. The organisms are Streptococcus aureus, which is most common. Then comes Streptococcus pneumonia, Salmonella, and Candida. The clinical features include acute presentations. Patients often appear severely ill. Fever, so since it is purulent pericardial effusion, so caused by some, caused due to some infection. So there will be hallmark symptoms of inflammation, that is fevers, chills, chest pain, pleuritic or non-pleuritic, and can be rapidly fatal as well. The diagnosis is ECG. ECG will show tachycardia, diffuse ST elevation with or without low voltage QRS complexes. The chest X-rays enlarge cardiac sellout and clear lung fields. Echocardiography will show pericardial effusion. Cytology will show turbid fluid with increased WBC, that will be neutrophil predominant, and increased protein and decreased glucose. Treatment is with intravenous antibiotics with pericardial drainage. Now let's talk about peripheral artery disease. It is atherosclerosis, right? It is the peripheral version of coronary artery disease. So basically in coronary artery disease, we are having atherosclerotic blockage of the coronary arteries. If the atherosclerotic blockage of some peripheral artery is happening, it happens mostly in the legs. So that is called as peripheral artery disease. What are the clinical features? Etiology: atherosclerosis due to the risk factors, for example, diabetes, hyperlipidemia, hypertension, smoking, age more than 70. Thromboangiitis obliterans, that is the Burgess disease. It is a medium vessel vasculitis which is more common in the middle-aged men who are chronic smokers. Okay, the clinical presentation, it is asymptomatic in 20 to 50% of the cases. Physical exam findings: decrease or absent pulses below the level of stenosis, occasional bruise over the stenotic region, poor wound healing in the areas of diminished perfusion, cool extremity with prolonged venous filling time, shiny atrophied skin with nail changes, foot pallor with leg elevation, that is a Burgess test. When we elevate the leg, the foot will become pale. Specific pain patterns: buttock and hip pain, which is caused by the aortoiliac disease. It is also called as Leriche syndrome. So if the patient is presenting to you with the pain in the buttock and hip region, so we will also have erectile dysfunction most probably, and that is Leriche syndrome and erectile dysfunction, and that will lead to impotence. Bilateral diminished or absent groin pulses, occasional bruise over the iliac and femoral arteries, muscle atrophy, and slowed wound healing in the legs. In Leriche syndrome, it is a triad of erectile dysfunction, buttock and hip pain, absent femoral pulses on examination. Thigh pain, aortoiliac or common femoral disease, normal groin pulses but decreased distal pulses. Calf pain is most common, increasing pain with excretion and decrease with rest. Upper two-thirds of the calf, that is superficial femoral artery disease, and lower one-third of the calf, popliteal artery disease. If we are having claudications, like calf pain presents with claudications, like when the person starts to walk and then he starts having pain. If the pain is involving upper two-thirds of the calf, so it is superficial femoral artery disease. So it is what? It is superficial femoral artery disease. And if the pain is in the lower one-third of the calf only, so it is popliteal artery disease. Foot pain is because of tibial or peroneal artery disease. The risk factors for the peripheral artery disease are atherosclerosis, diabetes, hypertension, and smoking. Presentation is with intermittent claudications. You will be asked about a person who is like 70 years of age and he walks a particular distance, and then starts having leg pain, and then he has to rest for about 20 minutes, and then he starts walking again. So this is a classical vignette for the peripheral artery disease. Diagnosis is done with an ankle brachial index of less than 0.9 is diagnostic. 0.9 is normal. If it is less than that, then it is you know 0.9 to 1.3 is normal. Like from 0.9 to 1.3 is the normal range. If it is less than 0.9, then we are having a diagnosis of peripheral artery disease. Then arterial ultrasound, it is less sensitive and specific than ankle brachial index, generally performed in symptomatic patients with abnormal ABI who are being considered for interventional procedures. Follow-up: patients with peripheral artery disease and intermittent claudications have future risk of cardiovascular morbidity and mortality. 20% 5-year risk of non-fatal MI and stroke. 15 to 30% 5-year risk of death due to the cardiovascular causes. management. All the patients with peripheral artery disease should undergo risk factor modification like smoking cessation, lipid lowering therapy, evaluation and treatment for hypertension and diabetes mellitus. Low dose aspirin and statin therapy is initiated because peripheral artery disease is considered to be coronary artery disease equivalent, and hence aspirin and statins are given to decrease the cardiovascular complications. Supervised exercise program, that is pain conditioning, so that the person can walk a longer distance without having pain. Exercise for a minimum of 12 weeks with 30 to 40 minutes of exercise at least 3 times a week is recommended for all the patients with claudications. The goal is to reproduce claudication symptoms during each session. Therapeutic trial of naftidrafuryl or cilostazol. Do this if exercise program is ineffective. Naftidrafuryl is preferred over cilostazol. Percutaneous or surgical revascularization, it is reserved for those who have persistent symptoms despite exercise therapy or pharmacological therapy. Limb-threatening complication, for example, non-healing ulcers. Significant limitation in activities of daily living. Then we have ankle brachial index interpretation. Ankle brachial index is calculated by dividing the higher ankle, dorsalis pedis or posterior tibial systolic pressure in each lower extremity by the higher brachial artery, that is left or right systolic pressure. So we divide the higher ankle, like out of the two, whichever is out of the two ankles, whichever blood pressure is, whichever systolic blood pressure is higher, we divide that with the higher brachial blood pressure. The normal is from 0.9 to 1.3, abnormal is less than 0.9, and if it is more than 1.3, suggestive of calcified and uncompressible vessels, additional vascular studies should be considered, like in people who are having diabetes or some other problem in which the vessels are so calcified that even after application of that, uh, the BP cuff, the blood vessels are not compressed. So then we have to do for what do we do then? Okay, I don't remember. I guess it was tibiobrachial index or something. But okay, we have to do some other vascular study. Hypertension, by definition, it is more than 140 by 90 on 3 separate occasions and 2 weeks apart. So normally, according to new classification system, the blood pressure, normal blood pressure is below 120 by 80. So systolic must be less than 120 and diastolic must be less than 80. This is normal. Then we have stages. Hypertension has two stages, stage 1, 2, and then there is also an elevated blood pressure stage. So for the elevated blood pressure, systolic blood pressure 120 by 120 to 129 and diastolic less than 80. This is elevated blood pressure. For these, we have to do the lifestyle modification and weight loss, exercise, dietary changes, reduced salt, alcohol in moderation, and DASH diet. The DASH diet is dietary approaches to stop hypertension. It is a particular diet which must be followed. In stage 1 hypertension, it is systolic blood pressure from 130 to 139 and diastolic blood pressure of 80 to 89. Lifestyle changes with or without one antihypertensive drug. An antihypertensive drug is needed if comorbid diabetes mellitus, CKD, or atherosclerotic cardiovascular disease, or 10-year risk of atherosclerotic cardiovascular disease is more than 10%. So in these situations, we can give one antihypertensive drug with the lifestyle changes. If we have stage 2 hypertension, like systolic blood pressure more than 140 and diastolic more than 90, so lifestyle changes with 1 to 2 antihypertensive drugs. A 2-drug combination is recommended if the blood pressure is more than 20 by 10 millimeters mercury above the target. Then check these before diagnosing it as primary hypertension. So we have seen this table before. Now let's revise it. So for the renal function test, we should perform serum electrolytes, sodium, potassium, and calcium, serum creatinine, urinalysis, and urine albumin creatinine ratio, that is optional. Endocrine tests include fasting glucose and hemoglobin A1C, lipid profile, and TSHB check for hypo and hypothyroidism or hyperthyroidism. In hypothyroidism, it is the ADH which is causing hypertension, and in hyperthyroidism, it is the sensitivity to catecholamines which is causing hypertension. Cardiac tests include ECG and echocardiography, it is optional. Other tests include complete blood count and uric acid, that is also optional. Lifestyle changes for hypertension. Firstly, we recommend the DASH diet. The recommended plan is diet high in fruits, vegetables, and low in saturated or total fats. Approximate decrease in blood pressure. So it can approximately decrease the blood pressure by 11 millimeters of mercury. We are talking about systolic blood pressure. Weight loss, reduction of BMI to less than 25 kilogram per meter square. So the reduction will be 6 millimeters of mercury per 10 kg loss. Aerobic exercise 30 minutes per day for 5 plus days per week. So approximate decrease will be 7 millimeters of mercury. Dietary sodium less than 1.5 to 2.3 grams per day. Response varies 5 to 8 millimeters of mercury. And alcohol limitation less than 2 drinks per day in men and less than 1 drink per day in women. So that will decrease 5 millimeters of mercury of blood pressure. Hypertension stages, again, we have talked about them. So moving forward. For the diagnosis of hypertension, screening blood pressure more than 130 by 80 millimeters of mercury. Evidence of hypertensive end organ damage or blood pressure of more than 180 by 120 millimeters of mercury. If yes, it is hypertension and start the treatment. If no, outside of office, average blood pressure more than 130 by 80 millimeters of mercury. So if no, like so then it is white coat hypertension. Only in when they come to you they have increased blood pressure, and when they go home the blood pressure is reduced. So it is white coat hypertension, and just give the routine monitoring. It is not hypertension. But if outside the office the average blood pressure is more than 130 by 80, so it is hypertension. Start treatment if blood pressure is more than 140 by 90. If less, consider the risks. Ambulatory BP monitoring for 24 to 48 hours or twice daily home BP monitoring for 1 week. Okay, like this one. Office blood pressure measurement. So how to do that? Patient position seated with back supported, legs uncrossed, arms supported at the level of heart. Examiner technique. Use appropriate size cuff and auscultate the brachial artery or use oscillometric device. Use the oscillometric device. Measurement of sequence. Have the patient avoid smoking and caffeine 30 minutes prior to readings. Have patient rest for 5 minutes between the readings. And measure both arms if discrepancy. Use the arm with a higher blood pressure. The common errors that can occur in the process are uh, cuff too small, BP falsely high. So the false high blood pressure can be measured if the cuff is too small, if the inadequate patient, if the patient is not having appropriate rest, the patient talking or not leaning against backrest, room too cool, anxiety, arm muscle is tensed or like due to the white coat hypertension. Blood pressure falsely low if the cuff is too large. So the size of cuff is inversely proportional to the false reading. If the cuff is large, the blood pressure will be low. If the cuff is small, the blood pressure will be high. Too quick deflation of cuff, more than 2 to 3 millimeters of mercury per second. Auscultatory gap, that is muffled sound above diastolic pressure. Okay, so like you made it falsely low because you did not listen to that sound that was coming before that. Blood pressure discrepancies, coarctation of aorta, blood pressure falsely low in the legs, and subclavian stenosis, blood pressure falsely low in the affected limb. So here you can see that left ventricular hypertrophy regression from antihypertensive. So the most beneficial effect according to this is given by the diuretics. Then comes the ACE inhibitors. No. It is change in left ventricular mass index. So this is the least with the diuretics. The maximum is given with the ARBs, like it is minus 10 or minus 12 something. Then comes calcium channel blockers, then ACE inhibitors, and then other diuretics. Then we have cutaneous causes of secondary hypertension. The causes of secondary hypertension are listed in this table. So the first, there are a lot. So the first one are renal parenchymal disease. That can be detected if there is elevated serum creatinine, abnormal urinalysis, proteinuria, red blood cell count, red blood cell casts. I'm sorry, renovascular disease, severe hypertension more than 180 millimeters of mercury systolic or more than 120 millimeters of mercury diastolic after the age of 55, possible recurrent flash pulmonary edema or resistant heart failure, unexplained rise in serum creatinine and abdominal bruit. Continuous abdominal bruit, also called as renovascular hypertension. Continuous bruit, that is systolic and diastolic, has 99% specificity for renovascular changes. Bruit heard on one side, periumbilical or epigastric or flank. Primary aldosteronism, easily provoked hypokalemia. I'm sorry, slight hypernatremia will be there. They will not be devastating hypernatremia because there is a phenomenon that we call aldosterone escape that does not allow too much sodium to be retained in the body. But hypokalemia, that can be easily provoked, will be present. Hypertension with the adrenal incidentaloма. Pheochromocytoma, paroxysmal elevated blood pressure with tachycardia, pounding headaches, palpitations, diaphoresis, hypertension with an adrenal incidentaloma, hypertension. Okay. Then Cushing syndrome can be a cause. So, but associated with the Cushing syndrome, there will be central obesity and facial plethora, proximal muscle weakness and abdominal stria, ecchymosis, amenorrhea and erectile dysfunction, hypertension with adrenal incidentaloma, hypothyroidism, is associated with the fatigue, dry skin, cold intolerance, constipation, weight gain, bradycardia. So it is actually the ADH, increased amount of ADH that is secreted in the hypothyroidism that can lead to hypertension. Then primary parathyroidism, hypercalcemia leads to polyuria and polydipsia, kidney stones, uh, constipation, neuropsychiatric presentations, confusion, depression, psychosis. So these are associated findings, like there will be hypertension and these findings will also be present. Moans, groans, psychiatric overtones. Then coagulation of aorta, differential hypertension with brachiofemoral pulse delay. In Cushing syndrome, you will find hypokalemia, hypomagnesemia, hypercalcemia, all can cause muscle weakness, like this one. You will not find these in Cushing syndrome. For muscle weakness, you must remember that hypokalemia, hypomagnesemia, and hypercalcemia, all of these factors independently can cause muscle weakness. Hypothyroidism, increased thyroid releasing hormone that will lead to increased TSH and prolactin. Why is it important? And there has been increased keratin kinase in hypothyroidism. Okay, hypertension definition, more than 140 by 90 on 3 separate occasions for 2 weeks apart. Okay, management of hypertension. For the people who are more than 60 years of age, initiate the treatment for more than 150 millimeters of mercury systolic or more than 90 millimeters of mercury diastolic. The goal blood pressure in people more than 60 is less than 150 by 90. If the age is less than 60 and chronic kidney disease or diabetes, the treatment should be started at more than 140 systolic and more than 90 diastolic, and the goal blood pressure is less than 140 by 90. Initial treatment choice in the black people, these are thiazide diuretics or calcium channel blockers alone or in combination. Okay. ACE inhibitors and angiotensin receptor blockers are not first line in black population. We can give thiazide diuretics and calcium channel blockers, each of them alone or maybe both of them together. Other ethnicities, thiazide diuretics with ACE inhibitors, thiazide diuretics, ACE inhibitors, angiotensin receptor blockers or calcium channel blockers either alone or in combination. All ethnicities with chronic kidney disease, then ACE inhibitors or angiotensin receptor blockers, they gain priority alone or in combination with other drugs. We have talked about that. Hypertensive complications. So the complication of hypertension can be hypertensive urgency and hypertensive emergency. Hypertensive urgency is severe hypertension, usually more than 180 by 120 millimeters of mercury with no symptoms or acute end organ damage. Hypertensive emergency means severe hypertension with acute life-threatening end organ complications. Malignant hypertension, it is basically an old term, but it is still used in literature. So it is malignant hypertension is blood pressure more than 180 by 120. Severe hypertension with retinal hemorrhages, exudates or papilledema. Hypertensive encephalopathy, severe hypertension with cerebral edema and non-localizing neurological symptoms and signs. Then we have malignant hypertension, when we call it so. Okay, let's complete this malignant hypertension and hypertensive encephalopathy. So in malignant hypertension, it is a hypertensive emergency seen in patients with long-standing and uncontrolled hypertension. The features are retinal hemorrhages, exudates, papilledema, malignant nephrosclerosis, acute renal failure, hematuria, and proteinuria. In hypertensive emergencies, the mean arterial pressure should be lowered by 10 to 20% in the first hour, by another 5 to 15% over the next 24 hours. An excessive drop in the blood pressure can lead to cerebral ischemia. It is very important because the blood vessels supplying the blood to the brain are accustomed or they are used to the high blood pressure. If we suddenly drop the blood pressure, there will be severe anoxia of the brain. So the mean blood pressure should be decreased by 10 to 20% in the first hour and another 5 to 15% in the next 24 hours. Hypertensive encephalopathy, it is associated with the cerebral edema due to breaking through vasodilation from the failure of autoregulation due to severe hypertension. The presentation is headache, nausea, vomiting, neurological symptoms like restlessness, confusion, seizures, coma, subarachnoid or intracerebral hemorrhage. So we'll keep the session till here and we'll continue with the isolated ambulatory hypertension in the next session. Until then, Allah Hafiz, fi amanillah, and take care.